Lovely. Okay, great. I'm going to be giving a case presentation of a really fascinating case. A lovely 20-year-old woman who we've been treating for over a year now, Schneider. So I'm going to give you the diagnosis, but you see here on the right is a large posterior mediastinal mass, which is really pushing the heart anteriorly, and the diagnosis here is IgG4-related sclerosing disease. The differential diagnosis and on histology, it can be almost identical to an inflammatory myofibroblastic tumor. And what makes these entities very similar is they're composed of two different cell types, an immunologic cell type, and then fibroblasts. And the important principle in treating these conditions is that when surgery is performed, essentially, if you don't, any minimal residual disease left behind becomes much more aggressive because you're dealing with fibroblasts that are already hyperstimulated, and then when left with a scar or an inflammatory stimulus, they become much more aggressive. So in a sense, it's sort of waking a sleeping dragon. And so we go from a debulking procedure, which removes most of the disease, but a little bit is left behind, and over time that this tumor goes from pushing the heart to actually invading the left ventricular myocardium, as you can see here on a T2 weighted axial MRI image. So the treatment of choice for this condition is initially steroids, and then our patient was treated with oral steroids and pulse dose steroids. Response wasn't optimal. We continued with immunomodulators, so a B-cell depleting agent, so MabThera, which makes sense in IgG4-related sclerosing disease since you're targeting B cells. And then she developed cataracts. She had dose-limiting. She had limitations to dosing due to the toxicity from steroids. And we started with methotrexate. Eventually asked the question of how else can we treat this more locally with less therapy, less medicine. You can see on the axial CT, PET CT, this is a very hypermetabolic mass, and again the T2 weighted image, which really shows this infiltrated mass into the myocardium. So the expression, if you have a hammer, everything looks like a nail. So I'm an angiographer, and my goal was to identify the blood vessels that feed the tumor and then deliver a high concentration, albeit a lower dose, of the drug on the principle that a higher concentration of steroids would have an effect where a systemic dose did not. And this has been shown in other conditions, most prominently in graft versus host disease, where you can give intraarterial steroids to the gut or to the liver and see a significant response even when very high dose of systemic intravenous steroids does not. So the first challenge, what you see here is the chest x-ray, and I'd like to draw your attention to this rhomboid-shaped retrocardiac mass here just below the surgical clips. On the coronal MRI, this is just the left hemithorax. This is the region of interest. You'll see that the mass is infiltrating beyond the left hemidiaphragm to involve a portion of the left upper gastric wall. And then on the sagittal view, the patient facing this way, you see the mass over here, which is again abutting against the posterior ventricular wall and infiltrating below the diaphragm. So this again is the region of interest, and the first engagement of a blood vessel was the left bronchial artery. So we have the heart over here, the catheter here, and this is the left bronchial artery, which supplies a little bit of the tumor, but is not of particular interest. We see hyperenhancement of the left pericardial wall. It was not treated from over here. But when we catheterized the left 7th intercostal artery and administered contrast there, after coiling the lateral aspect of this artery, we see what we would call a blush. What we're seeing is retention and hyperpermeability and retention of the iodinated contrast in that rhomboid-shaped mass, which is, again, behind the tumor. So now we also see it really extending below the diaphragm into the region of the gastric wall. So we've identified a significant source of a significant feeder of the tumor, and from this point, again catheterizing T8 and T9, seeing no significant blush there. Looking at the left gastric artery, seeing a little bit of hyperemia, but nothing again significant enough to treat. And then going into the splenic artery, looking for short gastric contributors. None of that was positive. When we catheterized the heart with the help of our cardiology, our cardiologists at Beilinson and also at Schneider, we see that there is some irregularity of the circumflex as it approaches the region of the tumor. And we see from the right coronary angiography that there is real significant tumor blush. So the main supply of this tumor is from the right coronary artery and from the 7th left intercostal artery. And this is where we chose to treat. So we gave the equivalent of around 300 milligrams of solumedrol intraarterially into these branches. And we combined that with another agent. So in order to increase the bioavailability of solumedrol, we used a novel formulation of liposomal solumedrol, and the advantage here is that the liposomes are passively targeted into areas of increased what we call EPR, so enhanced permeability and retention. So what we just saw in angiography, that the iodine is going past the blood vessels into the tumor. That same phenomenon occurs with the liposomes, and the liposomal structure allows better uptake of the solumedrol. With the combined effect, we're still treating her today, and I'll just go past through this for the interest of time, but just to show that this is the pre-treatment tumor, and this is what it looks like today, significantly smaller with some remodeling of the posterior myocardial wall. Again, we're still in the middle of treatment. So her last treatment was just 2 weeks ago, and her next treatment is in about a month. We have 6 more planned doses, and then hopefully we can stand here next year and give you some better, more definitive results. So thanks for your time. I leave this slide only because, so we've noted that there are significant toxicities systemically, sometimes years later, when drugs are given for the purpose of treating a kidney and affecting the heart. And part of the idea behind giving targeted therapy, both mechanically and molecularly, is that you can serve as sort of a UPS delivery system and package the drug appropriately so that it gets locally to the right area and packaged so that the right cell takes it up, and in that way reduce toxicity, whether it's to the heart or any other organ. Thank you.